Okay, good morning, everyone. We're going to go ahead and get started. My name is Erin Flynn, and I'm the ACO and Practice Transformation Director at the Department of Vermont Health Access, and it's my pleasure to welcome you all to the first in our series of webinars being offered as part of the Vermont Healthcare Innovation Project's Core Competency Training Series. We're very excited to delve into a diverse and robust agenda today around the topic of providing high-quality care management across and between organizations, challenges and tips for success. But first, I wanted to cover a couple of brief logistical points. On this slide, you see a screenshot of the webinar control panel. You each have one. This is your tool for participation in today's webinar. Under the header audio in your control panel, you will see two options, either telephone or mic and speakers. By default, the webinar will connect to your computer's audio. If you'd like to change this, please click on the telephone button and you'll be provided with call-in information to call in. To ask questions or post comments, please type those into the question box on your control panel shown here. All participants will be muted in today's webinar in order to optimize sound quality for the duration of the webinar, but we do hope that you engage in a robust dialogue, and we encourage you to pose any questions or comments using the question box that I mentioned previously in your control panel. We do also want to notify participants that this webinar is being recorded and will be made available for future training purposes. Okay, I'd just like to spend a moment reviewing our learning objectives and agenda for today's webinar. Many of you may recall that a pre-survey was distributed at the beginning of the Core Competency Training Series, in which you were asked to indicate which training topics were of greatest interest to you. The most requested training topic in that survey was how to plan and coordinate care across organizations. Improving cross-organization care management is a focus nationwide, and especially relevant here in Vermont, given our rich infrastructure of both medical and community-based services working to address health issues and the social determinants of health. The Integrated Communities Care Management Learning Collaborative that many of you are participating in is supporting this challenging work. As many of you know already, our trainers from the Primary Care Development Corporation, join us from New York, where they are involved in a care coordination learning collaborative with similar goals. We're very pleased that for today's webinar, they have invited a panel of participants in New York's collaborative to join us and share what they have learned about best practices in this emerging focus area. We hope that you will also share your experiences with care coordination in Vermont with our colleagues from New York as we engage in a facilitated discussion. Go ahead. Just a brief overview of the agenda. We will facilitate a panel discussion amongst the New York panel providers, and then at 12:45, move on to a Q&A session amongst all participants in today's webinar. At this point, I'd like to turn it over to Carla Silverman. Oh, I guess I didn't like that we put my picture in there. So I'm the host. This is Erin Flynn, and there's my lovely picture. So I'm going to turn it over to Carla Silverman, who's our Interim Chief Program Officer from the Primary Care Development Corporation, and she's going to introduce you to our panel of providers from New York and begin to facilitate today's panel discussion.
Great. Thank you so much, Erin. This is Carla Silverman. I'm guessing that I know most of you on the phone since we have been providing training for the last couple of months in Vermont, and are looking forward to continuing that work with all of you. Just a little bit about my background for those of you who don't know me. My training is as a registered nurse and a certified nurse midwife, and I spent many, many years in safety net provider organizations and federally qualified health centers providing care. I now head up the care coordination and care training work that we do, and it's a real pleasure to be here today. I'm thrilled about our panelists, and I'd like to introduce them. They all have been involved in the learning collaborative that Erin mentioned that we are wrapping up here in New York, and then I'm going to tell you a little bit about that learning collaborative and its goals in just a moment. But first, I'd like to read our panelists' bios so you have a little bit of background on who they are. So our first panelist is Carlo Francis, and he's a licensed master's level social worker and the Deputy Director of Care Coordination for Community Healthcare Network's Health Homes program. In his role as Deputy Director of Care Coordination, Carlo is responsible for overseeing the care coordination services in the Brooklyn, New York region, which is comprised of 4 community-based health clinics and 1 administrative site. Carlo focuses on employee development, training, and quality improvement. Additionally, Carlo collaborates with interdisciplinary teams to help Community Healthcare Network develop processes to achieve the goal of providing integrated services that focus on team collaboration and patient engagement to drive improved health outcomes for patients. Our next panelist is Jillian Gross, who's a master's level social worker and the operations manager for Central New York Health Home Network. She is responsible for overseeing the central region in upstate New York. That's Herkimer, I'm sorry if I don't pronounce these right, Oneida, Madison, and Cayuga counties. I don't think it's that far from some of you in Vermont. She works collaboratively with network partners, including insurance companies, LGUs, care management agencies, network providers, community partners, ACOs, and regulatory agencies to assure that clients receive their necessary services needed for their care. Jillian supervises the CNY-HHN program managers in the Utica and Auburn offices. And prior to working at CNY-HHN, Jillian was a therapist at a residential facility for children. She's held positions in care management agencies as a case planner, family support specialist, and behavioral specialist. And she graduated from University of Albany with a master's degree in social work. Our last panelist is Ari Rossner, who's a licensed clinical social worker, and she received that master's in social work from Columbia University in 2009. She's worked at Mount Sinai Hospital since June 2009. For the first several years, she worked in the renal transplant department, where she followed patients through all phases of the transplant process, pre- and post-transplant, while hospitalized and in the community. Since February of 2013, she's been working with the Health Home Care Management Program, and in 2015, she became the co-director of the Health Homes Program for the Mount Sinai Health System. In 2014, she presented the Society for Social Work Leadership in Healthcare regarding social work's involvement in new government-designed care coordination programs. She later co-authored a chapter in the Society for Social Work Leadership in Healthcare's publication, Advocacy in Healthcare Social Work. Participating with other social work leadership at Mount Sinai, she also co-authored an article in Social Work in Healthcare on the development and implementation of the Health Home program. She's a teaching assistant at the ICANN School of Medicine at Mount Sinai, where she facilitates small group sessions for the first-year course, the Art and Science of Medicine, and the third-year primary care clerkship. So welcome to the panelists. We're really thrilled to have you. I'd like to just talk a little bit, maybe we could go to the next slide, Erin, talk a little bit about our project. And yeah, thank you so much. So for everyone on the call from Vermont, I just want to kind of set the stage and give you a little context before we get into our discussion. PCDC has been facilitating a learning collaborative over the last year and a half, and everyone in all the organizations who participated, and we had some organizations who were from New York City and one that was upstate, that's where Jillian is from, all of them are involved in the New York State Health Homes program. And that is a care management program that covers Medicaid patients. It comes through the New York State Department of Health, and it provides fees or payment to organizations who care for Medicaid patients with multiple chronic conditions or serious mental illness or HIV or some combination of those things. The providers receive a payment each month to provide those services, and some of the tasks they're involved in are outreach and enrollment, doing health risk assessment, creating and updating care plans, and following up after critical events such as hospitalizations and ER use. And the ultimate goal of this program is
Sounds like you've got a little bit of background noise, so just a reminder to mute your phones if you're not speaking.
The ultimate goal of this New York Health Homes program is to reduce ER use and inpatient admissions, improve clinical outcomes, and decrease cost. So I share that with you just to kind of give the context, but I can tell you that our panelists, some of them also are involved in other types of care management that are not part of the Health Homes program, but you will hear that referred to a little bit in our discussion. Next slide. So just to talk about the initiative that we have been working on here in New York, it was called the Integrated Care Planning Initiative. It was a learning collaborative with 5 safety net provider organizations from New York State. And the goal was communication and collaboration between medical providers such as doctors, nurse practitioners, physician assistants, and behavioral health providers, mental health providers, and the care management team or providers. And just briefly, the way we did that, each organization had a small change team. The change team was composed of a doctor, often a mental health professional, someone from the care management side or staff, and then frequently we would have an administrator or IT person or someone else involved. And these small teams worked on how they could improve these collaborative processes to better the delivery of care management services. Next slide. So just to talk about some specific goals that all the teams worked on and that you'll probably be hearing some of the lessons learned from those goals today. Most of the organizations worked on setting up interdisciplinary case conferences where you actually had doctors, nurses, care managers, mental health professionals, sometimes administrators or front desk people sitting together working on the care planning process. This relates to the second goal, which is we really were trying to move people towards an integrated care planning process and trying to move people away from each separate department doing their own care planning that might or might not have been shared with one another. Many organizations worked on increasing referrals into the care management program. So in New York, and I'm imagining in Vermont as well, there are many patients who are eligible for these care management services who may or may not be getting into the program. So we had a real focus on how to increase referrals, and we'll talk about some strategies later today to do that. We focused on engaging doctors in the care management program because we saw that there were silos, both cultural and related to infrastructure, that kept doctors and care managers in kind of separate spaces, and we really have worked to break down some of those boundaries, and the panelists today I think will have some interesting insight to share with you on that. And then finally, we worked on trying to coordinate processes for follow-up with patients after critical events, such as ER use or unplanned hospitalizations, and we'll talk more about that today. So just to kind of give you an overview, these are the things we're gonna talk about, and we'll probably just stay on this slide for a little while. I think what I'd like to do now is ask each of my panelists if they could introduce themselves and just say a little bit about what kind of organization you work for, what kind of patients you provide care coordination for, what types of staff actually do the care coordination, and how you get patients into the program and what those processes look like. So maybe I'll ask Ari if you could start, and then followed by Carlo, and then Jillian.
Sure. Hi, everyone. Can you hear me okay?
Yeah.
Okay, great. So as Carla mentioned, I'm one of the co-directors for health home programs at Mount Sinai Health System. So this is a fairly large health system in New York City. There are 5 hospitals in which we're working within care management. There are 7 hospitals in the system, in the whole system. So as far as the care management that I will mostly speak about today, although there are some other care management programs that we are sort of simultaneously working on within the health system, is the health home program. And, as Carla mentioned, this is a program for patients who have active New York State Medicaid and multiple chronic illnesses or serious mental illness or HIV. And as far as how we have the care management system developed is we have an internal staff of social workers and care coordinators who are placed at the various hospitals within our system. And we are focusing their efforts on patients who we know are at a high risk of readmission and overutilizing the ED, the emergency department, and who are accessing our system, but maybe not so efficiently. So we have social workers and care coordinators sort of dedicated to certain practices and units within both the behavioral health side and the medical side of the care that we provide. And we are trying to sort of find them in the place where they are in sort of an acute moment and need the most help. That's where we see we have the most success, and roll them into the care management program and then work with them ongoing, not only within the hospital and clinic walls, but outside into the community as well, to really try to bridge the medical, behavioral health, and community support services that they're receiving. The social workers and care coordinators work together in teams and really act as point people for all members of the care team. So that includes primary care provider, primary mental health or behavioral health provider, and oftentimes family and caregiver support. So we do have sort of an outreach portion of our program as well for patients that are identified by the New York State Department of Health or even by internal sort of high-risk stratification strategies. And so we also have a sort of centralized outreach group that tries to connect with these patients both via phone and in person, and then try to connect them with a care manager that does ongoing work. So I know we'll talk more about this later, but we've done a lot of work in partnering with specific clinics in primary care and in behavioral health to make sure that the physicians within our health system are aware of what the care management programs are, and to really work with them closely to make sure that we're all aware of what we're each sort of doing for the patient, what the patient's goals are, and really trying to, in a patient-centered way, move them towards self-management.
Great, thanks, Ari. I don't remember actually who I said was going next. Carlo or Jillian, can you share about your organization?
All right. Good morning, everyone. I'm Carlo Francis. Like Carla said, I am one of the deputy directors for care coordination for Community Healthcare Network. We are a community-based organization comprised of 14 health centers. We serve close to 90,000 New Yorkers of all ages. We provide primary care, we provide pediatric care, we have a very robust social service branch that health homes falls under. And like Ari explained, what the whole health homes is about patients with active Medicaid who are dealing with 2 or more chronic conditions or severe mental illness or a combination thereof. We function as a lead health home, so we have a contract directly with the state and the managed care organization. And we also have an internal care management agency which provides care coordination services to the health home patients. And we also have around 19 downstream providers, we call them, who are subcontractors, who we also provide. We send names from the list we receive from the managed care organization and from the state to do outreach and provide care coordination services for. In terms of how we provide services, the health homes, we've decided that we would connect teams to all of these clinics so that there's a health home presence, even though they may not be always physically in the clinic that offices are, but that one person is always available in the clinic so that if a provider has a referral or if a patient needs someone from health home, we have a presence, and therefore the providers and folks working in the clinic will know more about health homes and see our usefulness to them. Yeah, so that's what I can say about the agency right now.
Great, thanks, Carlo. And Jillian, can you talk about your organization?
Yes. So we are Central New York Health Home Network. We're upstate, so it's a little bit different in terms of our outreach strategies and just engaging patients just because we're more rural. So I'll get into that, but we are a lead health home. Like Carlos said, we contract. However, we do have internal staff. So Central New York Health Home covers 7 counties. I oversee the central region. However, we do have some northern country folks who cover St. Lawrence, Jefferson, and Lewis County. So they're way up touching the Canadian border. So they're also rural. Our 4 counties that we serve here in the central region have, I believe, 15 contract providers, and we're growing every day. Health homes is one of the care management facets that we handle here. So Central New York Health Home is a lead health home. However, we are an affiliate of UCP, which is a major agency up here, really focusing on the OPWDD world, so persons with developmental disabilities. And they have, I think, 47 houses at this point, residences, so they are very large in that world. However, we have grown, so now UCP also has a behavioral health clinic, 2 as of last week, so 2 behavioral health clinics here in Oneida County, and also we have primary care and some school-based health centers. So I focus on the health home component of all of that. We have an outreach team and we have care managers. So our outreach team is not specifically located to a clinic or an area just because we are more rural. So they're really a street-level outreach team. They're mobile. They have mobile offices, and they're really on the move a lot of the time, doing door knocks, cold calls. So those they're meeting people more where they're at. So it's not so much a facility. However, we do have some people embedded within facilities. A lot of ours is just getting in your car, picking a neighborhood, and spending half the day knocking on doors and passing out flyers. And I think that pretty much covers us. A lot of what we do has already been said, but we are lead health home serving adults in upstate New York and soon to be kids starting in October.
Great, thank you, Jillian. So I'd like to just dive right in and kind of get to a kind of more ground level discussion, because I know, from working with the folks in Vermont that, right, it's smaller in Vermont, obviously it's rural, a lot of people know each other, and so I think anything that we can share about the on-the-ground care that we've been seeing in New York would be helpful for the Vermont folks. So I'm going to ask, let's see, one of the panelists, maybe Jillian, you want to take a stab at this. Just can you talk about some of the processes that your organization is involved in, where you're collaborating with outside organizations, and maybe you can just mention at the same time some of the challenges that you face there and some solutions that you've come up with.
So across agencies, what we were looking at are two different approaches. One being that we can physically place some of our outreach staff and our care managers within facilities. So since we're lucky enough to have a primary care and a behavioral health clinic be an affiliate of ours, it was very easy for us to kind of set up camp in there and engage doctors, engage staff, engage therapists on a day-to-day basis and do education to clients frequenting the clinic. And that again, we're rural, so that works very well. However, we have not as many opportunities to do that, and that is because physical space is very limited here. So when you're asking a clinic or a primary care to give up space when they're already kind of smushed together is difficult. So we've got creative with doing half days. So we're working with probation and parole, and they have helped us kind of with the scheduling, and they've worked on scheduling more. They're Medicaid eligible health home folks for care management on Mondays and Tuesdays. So that has helped us. So we've really worked with providers to talk about what's the best time for us to come in, when are you available, where can we sit. Again, the mobile offices have been very helpful. It allows us to kind of move around, use a lunch table, whatever's necessary to kind of set up. And then we have the external care managers who are actually housed in our offices, and they go out to the client's home or the client's appointments. And the struggle with keeping providers in the loop with that has really been the communication. So as a care management agency, we document everything in one system. And how do we get that information back to the providers? How do we find when the providers are available? Everyone in terms of a system is still working in their silos. So that, a phone call is not always the easiest thing to do. You think client's assigned, care manager picks up the phone and calls the doctor and says, hey, they're assigned. There was a lot more steps to it that we are still working out, but do you call the nurse? Do you call the doctor? Where do they put it in their system so that the next nurse who sees that client knows who to call? What kind of updates do they need? So we worked we worked through it somewhat with huddles. So what we do now is that at some of our mental health clinics, and we're trying at probation, is to get there 15, 20 minutes twice a week and make sure that the providers are getting time blocked out, almost like an appointment. And we block that right out, and we use that 15, 20 minutes twice a week to get as many people as we can in a room. And it's not much time, but if you can come with an agenda, come with really roles and responsibilities hammered out, you can use that time for communication purposes. So you can see the nurses and read them the list of clients that recently enrolled, ask them where they're putting it in their system, how they're keeping track of it. So all of that is done now in huddles and case conferences that seem to be the best for us.
Great. Thanks so much, Jillian. So, right, blocking time on provider schedules, having huddles, which I'm imagining some, in person, but maybe some people are calling in if they're not at the actual agency. And it sounds like also having patients try to have them come in on particular days when the whole team is there. Sound like some strategies that you've come up with. Carlo or Ari, can you talk about some of your interagency processes, some of those challenges, and any solutions that you have come up with?
Sure. So I don't know if I mentioned it before specifically, but similar to what Jillian described, we are also a lead health home contracted with New York State, in addition to having our own internal care management agency that sort of provides services on behalf of that lead health home. In addition to our own internal care management agency, we have 24 other care management agencies who provide the services on behalf of our health home. And so because of that, we have a lot of sort of interagency interaction and discussion, and it's been really helpful in sort of, learning some lessons ourselves and getting tips from the community-based care management agencies and sort of helping that flow of information. It's also allowed us to better connect the community-based care management agencies to our health system practices and physicians. So something that we've put into place that I think has been pretty successful is for patients that we are being referred within a primary care setting, for example, we sort of do an assessment. We triage the patient from a care management perspective and decide, is this someone who would really benefit from receiving a care manager from our internal staff, meaning they receive a lot of their care at Mount Sinai, they're in the clinic very regularly, and need someone that's, all the time accessing all of their providers, versus someone who goes to primary care in that clinic, but most of the needs are really truly community-based. They have a lot of housing challenges or need regular visits to the Social Security office or assistance with entitlements, and that might be a better patient to connect with a community-based care management agency. And so we've developed a sort of enhanced relationships with certain of our contracted care management providers in the community, and have set up very specific workflows to make sure that there's very easy communication between the care manager from the community-based agency who's following the patient to be able to connect back to the physician and social worker that work in an actual primary care practice. So we sort of modeled it first in primary care, and now we're doing the same thing in a lot of different types of areas, like an emergency room in Queens, in inpatient psych units at two of our hospitals on the west side of Manhattan. So I think this is a model that's been working for us, and it's been also really beneficial to the community-based partners who have had an increase in their enrollment because we are sending them these referrals. I'd say the biggest challenges with that is first, sort of, it's always challenging to assess risks, to make sure that we're managing the right people in general. And then to make this communication possible between the practice and the community-based agencies, IT and sort of communication systems is always really a challenge. So we've developed many workarounds, but I think sort of the long-term goal is really to put a health information exchange in place that our health home providers can have access to, so that there is a way to have a flow of information. I think it's really critical in moving this kind of work forward.
Thanks, Ari. So just to summarize what I'm hearing and what I know, that you guys are now, you have this process where you're triaging and doing a sort of more complete assessment of the needs of the patient, and then deciding who is the most appropriate care manager or care manager agency for them. I'm wondering, just knowing what I know about how Vermont works, whether, how much patient choice is there, and do you have, are you finding any issues with that? How do you kind of explain this to the patient or roll this out? Because I think the Vermont folks might be curious to hear about that.
Sure. So in speaking with the patient, I think so the triage worker is a social worker who does sort of a brief assessment that's almost like a screen to determine the needs, and then is able to describe the health home program, and to describe, and in doing that sort of screening of needs, determines what types of agencies, if any, the patient's already connected to. And I think that's how we, there is always patient choice, but I think that's how we help direct the patient to an agency that makes the most sense for them. I mean, one is, one benefit to certain agencies is that we do have this ability to share information and have this direct communication, so that they are sort of an extension of Mount Sinai and able to connect more easily back to their doctor or other providers. Another thing is to look at really what the primary need is. So, we've tried to create a diverse network within our health home of, agencies that provide mental health services, substance use services, housing providers. And so, although they're all providing care management or care coordination services, they do have usually a certain sort of level of expertise in a particular area. And so we would try to match then also the patient's particular need and geography to whichever agency makes the most sense for them.
Great, thank you. Carlo, can you talk about some of the interagency care coordination processes that CHN is involved with, and some challenges and solutions that you guys have come up with?
Right. For us, because of the situation where housing is concerned in New York City, where a great number of our patients, that seems to be a major challenge in them accessing care and staying in care, we were able to form a relationship with some of the major the shelters, homeless shelters. So right now we are embedded in 3 of the shelters, 1 in the Bronx and 2 in Manhattan, where we have health homes, a care manager, and a patient navigator working with administration there. So we get a space that we can set up, and patients are being referred to us. That helps us to know when a patient's moved into a shelter, that we get information as to where they are, and that we can help them to continue their medical care while we assist them and work collaboratively with the shelter folks to help them find permanent housing. We've gotten quite a significant amount of consent out of that, as well as successes in ensuring that a person finds somewhere to live. And then we started a collaboration with the Woodhall Hospital, which is very close to one of our clinics in Brooklyn, and we found that we shared quite a significant number of patients. So our AMD met with the hospital administration, especially from the ER, and we started working with them to try to redirect the patients away from the emergency room when it's for matters that could be handled by the clinic. So we will get calls that one of our patients is there, so we pop over. And we work with the hospitals to make sure that patients are taken care of in terms of working on whatever needs to happen for them in the community while they're in the hospital. And so generally, health homes will receive admissions alerts from the managed care organizations. Sometimes those come a little later than would be ideal because the insurance companies learn about those through the billing process. And now we're able to get, in some cases, real-time alerts from the hospital. Somebody will call us and say, hey, you know, patient X is here waiting to be triaged. Can you send your care manager over? So we're beginning to expand that, and that is working very well for us. Those are the two that I can really think of most.
Great. Thank you, Carlo. So it sounds like, again, if I can just sort of pull out the key ideas here, that your agency is working with leadership at other agencies to establish these relationships, and you know, then you have things like you can be working more closely with the homeless shelter or with a particular hospital, right? But it sort of started at the leadership level to build those relationships.
Absolutely.
Great. So just because I'm conscious of time and we have so many good things to talk about here, one, I just want to make a reminder to the people listening to this webinar that if you are thinking of questions as we're talking, please type them into the chat window on the right-hand side of your screen, and we will be addressing those later on in the session today. I think I'd like to jump, panelists, to a topic that I know is of interest, which is engaging doctors in your care management program. And I think I'll call on Ari maybe to start this discussion and to kind of share, I don't know, what you thought, let's say before we started the Learning Collab, you know, over a year ago, sort of what the situation was in terms of your docs, maybe your residents, and then any solutions that you've come up with and changes that you've seen in terms of engaging doctors in the care management program.
Sure. So I would say, you know, when the health home started, it's not very publicized, and you know, a lot of people know about it and a lot of people don't know about it. And I think that at a large academic medical center, you know, we have staff that are constantly rotating through. So we have a lot of our clinics are resident run, and you know, there's residents and fellows that are changing every year. And so it's a challenge to sort of capture everybody in one spot. But I would say what we started with, which I think is really important to start with and then to keep doing, is to, you know, go to all of the different departments in your agency, or if you work at a hospital, in your hospital, you know, whoever the people are who you think would be excited about their patients receiving these type of services, to go and, you know, do a roadshow. You know, we went to sort of all different departmental meetings, to grand rounds for the social workers, for ancillary staff, for different medical providers in primary care, in psychiatry, in pediatrics. We get a lot of referrals for parents, even though the Children's Health Home hasn't rolled out yet, we get a lot of referrals for parents, for children who are receiving care within our health system or at certain community-based providers that we have contracts with. So I think that initial sort of education is really important. We also learned very quickly that although there are different programs and, you know, different eligibility requirements for the programs, it's we can't really leave it up to the providers to be the ones to determine eligibility, and we don't really want to leave it to them. So, you know, another key thing I think is just to say, you know, send the patients our way, and then we'll find the right thing to connect them to. We have these services here, and you know, this is we'll make the determination who can work with the patient. You don't have to worry about sort of checking through these eligibility criteria to see if it's a match. And then sort of the next level down, we from doing those larger presentations, it's very quick to find sort of the people who get really excited about this type of work. And so we found it really beneficial to focus in those particular areas. That's where we started, in particular practices where there was an administrator or a physician who was really excited about incorporating this into the day-to-day workflow, because then you have sort of a champion to really push this forward. So we started sort of working in those directions, and then getting to a more granular level of figuring out exactly how we can flag these patients in our electronic medical records so that providers know who has a care manager. We started creating templated emails so that it was very clear to a provider when they had a patient who was enrolled, what the patient's goals were, and when a care plan was being updated, when something was being asked of them versus just an update from the care coordinator side. So I think that interdisciplinary collaboration and developing the communication strategy was really important. And then we went, to orientations for all of the residents. We did that, very regularly. And showed them this is going to look like, and then I think sort of the last thing is to really always ask for feedback. We all, as different types of providers, have different pressures on us all the time, and so we've really tweaked our workflow over and over and over again to make sure that it's as efficient as it can be, and as to make the communication between providers as easy as possible.
Great. Thank you so much, Ari. So just to kind of highlight, again, what I heard you say, you guys went on a roadshow. You provided in-servicing to doctors, residents, anyone really who was going to be interfacing with the care management program, face-to-face contact. I like this idea that you found your clinical champions, right? You sort of the low-hanging fruit. You identified the doctors who seemed excited about care management, and you started there in terms of building relationships, and then they could be the voice for talking about how useful your services were. You talked about better identification in the EMR or in the patient's chart about people who were receiving care management services, and then you talked about asking for feedback so that you could be adapting and kind of tweaking your workflows so that it integrated better with the other providers. So thank you, that was great. Jillian, can you share your challenges and solutions around this issue? I know you guys worked on this a lot at Care Management of Central New York.
Yep, so we kind of did a similar thing in terms of getting out to everyone multiple times and being mindful of staff turnover. So really checking up with everyone and doing the same presentations, making sure they have all the information they need. We also identified at first what we did was identified some folks that we really thought were going to carry the message for us when we weren't there. However, again, with turnover, what we learned with help from PCDC is to assign tasks or to really look at roles instead of specific people. So we started, looking at a medical champion and starting to look at not just, one person going out there, but is there a group? So if one can't make it, can the nurses fill in and kind of be this leader if the doctor's out for 2 weeks or anything like that? So we really started looking at it from a larger scope. In terms of engaging doctors specifically and nurses, we found that data was very helpful. So we started small and pulled out some sample cases, about 40, that were very medically in need, and just did some statistics around them. So did they receive their annual care or their annual physical? What was their attendance like? And that took a lot of work with the data record folks because we don't have access to that EMR for those primary care. So it took a lot of coordination, but we were able to get some really good data, and that helped spur the conversation. So when you walk into an office, and not only do you have a message and some information, you have some data that is pertinent to them. that, is recent, new, and really finding measurable outcomes that mean something for them in their own benchmarks.
Great, thank you. So I think that piece about using data is so interesting and important, and just even something simple like what you did. I mean, I hear it wasn't simple since you're in a different IT system, but getting things like showing how many patients who are enrolled in care management are attending their annual physicals, or tracking their no-show rates, or I know, Jillian, you mentioned to me maybe they still no-showed, but they actually called and rescheduled the appointment, which you took to be a sign of engagement, and I would agree with that. So using the data to kind of make the case with the docs that these services help their patients and can help support them as well. So Carlo, can you talk about challenges you guys saw at CHN around this, and how you approached this issue engaging doctors?
All right, we were dealing with the same issue, although we have many of our patients that are getting medical care or mental health services at one of or multiple of our clinics, and our providers they didn't know much about what health homes did, who we were, so we had that issue, as well as providers in the community. And so the lead health home came up with a flyer specifically targeted to providers. And so whenever we got an assignment from the state, and we learned that once we engaged the patient, we would then send that flyer out, an introduction letter along with the flyer to the providers of the patient, in preparation for us going out to meet with the provider and kind of say, we have a number of your patients in our health home, and this is what we do, this is what we can help you with, how do you see us working together? So that's for the external providers. For the internal providers across the Bronx, Brooklyn, Manhattan, and Queens, we were lucky that CHN's top leadership, Dorothy, our VP of Social Services, she was totally on board. And so there were provider meetings that we started to do, presentations to the providers to help them learn more about health homes. And then we had to streamline the referral process. And just like Jillian said, the data was really very important for people to see how many patients were qualified for health home services that these providers saw, and looking at our no-show rates and what how we could probably turn that around. And so we were able to then make sure that there's a health home person in every lobby of every one of our clinics every single day. And so the providers can easily say over the announcement, health homes person, please come to exam room 4. And somebody pops into the room and just talks with the provider and the patient right there. The warm handoff was fantastic. And so the providers started seeing their patients more. We would go pick them up and bring them to the appointment, bring them with their medication for reconciliation, things that they were not able to do prior to working more closely with us. But that took a while for us to get to that stage. And I think the Learning Collaborative was very, very instrumental in turning that corner for us, to move us out of those silos that we were working in before, even with our own providers.
Great, thanks, Carlo. So again, to summarize, I love this thing of, you have a flyer, it summarizes what the care management program is, and you have an introductory letter that goes to the providers, right? I mean, thinking like, oh, you
yes.
need to pay the patients, but this is a letter for the doctors and the clinicians saying, here's who we are, here's what we do, here's the benefits we provide, we're working with your patient, here's how you can reach us. I know that PCDC worked with many organizations on this kind of thing, and it sounds so simple, and yet I think it makes a huge impact, right?
Yes.
The other thing is when you can increase enrollment, right, then often there's that means that patients who need these services are getting them, and that means organizations are also getting paid to provide these services. So it's like a it's a win-win. I'm going to pause here for a moment just because it's 10 to 1, although I have many other topics that we can talk about, and just remind everybody, if you have questions, we would be happy to take them. Those of you listening to the webinar, you can type to the right-hand side panel on your screen any questions you have about anything that we've talked about or anything related to these topics. And I think maybe we do have some questions. Is that right? Vermont, do we have questions?
Yep. So the first question is, would you be willing to share, I think this is for Carla, would you be willing to share a copy of the flyer and some of the other tools that were mentioned?
Yes, I'll just need to speak with my my marketing folks to see if I have it and if we have clearance to do it, and then I would be happy to.
Yeah, and we also, PCDC worked with CHN and other organizations actually in a previous project, and we have some introductory letters for providers, templates that we can certainly share. And yeah, Carlo, if we can get your flyer, if that's okay, we can share that with Vermont as well. That would be great.
Absolutely.
Okay, one more question. Just generally, how is it determined who is the health home agency or the health home for an individual?
Hi, this is Jillian from Central New York. There's a couple ways. One, Department of Health gives us batches of lists each month that say these people are eligible for your service, and the other one is what Carla was talking about, those warm handoffs. So really, once you educate the community, they start to tell us who's eligible. They know the criteria, and whether that's a quick screen that they do internally within their own office, or they ask us, provide materials so that clients self-identify. It really comes in all different kinds of forms, but it's self-reporting at first. So how we do it as a health home is you say that you qualify because you have 2 chronic conditions. On our end, we have 90 days to get that supporting documentation to actually confirm that you have those conditions that qualify you. So it's all per patient report on the front half, unless it's coming from a hospital or somebody that can provide you with discharge information, or they have a consent to release personal health information. Other than that, it's client report or a DOH list, and then we have 90 days to reach out to providers and get the necessary documentation.
Great, thanks. So Erin, do you have more questions, or should I have another topic if you do not?
Yeah, one more. I'm interested to know more about the triage, quote-unquote triage workflow for determining which avenue to use for care management that was mentioned. Would you be willing to share?
Yeah, I think, Ari, that's referring to what you talked about.
Yeah. So we have the area where we started sort of piloting this workflow is in a very high volume care clinic that's resident run. So residents are the PCPs, and there are almost 15,000 patients that are seen within this clinic. So we do have social work staff who work within the practice who are not the people doing ongoing care coordination or care management, but they are sort of receiving referrals from doctors real time for, sort of psychosocial triage, we call it. So it's kind of putting out fires, helping patients with a one-off need or with a crisis situation. So all of the patients who require social work services are now directed to those particular triage workers, and we have point people for the different areas of the clinic. It's sort of broken into 4 sections, and the patient goes to that particular social worker, and that social worker does a brief assessment or screen and determines from what they're hearing from the patient, is this something that they can take care of quickly? It's, a transportation form that needs to be completed. It's a referral to home care, but, probably that will cover the patient's need. might be helping with a specialty appointment, things like that, they would manage on their own, the triage social worker would. And then if it's a little bit more than that, then they have sort of different avenues that they can refer to within sort of the social work coverage of the clinic. So there are additional social workers who can do sort of that medium term, let's call it, intervention where, it might take a month to complete it, but it's not someone who needs ongoing care coordination services. And then we have sort of the long-term care coordination needs. And for those patients who, I would say it's fairly easy to determine those patients. They might come and say that they want, that they feel that they need home attendant services. And once you start doing the assessment, you realize there's a lot going on here. This patient needs at least a couple months of services. And so that's when we would determine, are these services more community-based or are they more sort of health system-based? And determine if we're going to have the ongoing care coordination be done by an internal staff member versus a community-based care management agency. And, we have tools and time frames and all of that sort of built into these workflows, but that's the general idea. It's a little bit easier somewhere like an inpatient psychiatry unit where there are social workers doing discharge planning. Health home is a potential service that can be provided upon discharge for a patient who's on the unit. And so then we have a point person from our internal staff who is able to come to the rounds of the unit, do the sort of initial engagement education about the health home care management program and enrollment if the patient's interested, right then and there before the patient's discharged, and then we can make that connection to whoever is going to do the long-term care management. So I would say it's most complicated in the primary care setting and a little bit easier from the inpatient setting.
Great, thanks, Ari. So Erin, do you have any more questions there?
I'm going to be a little bit selfish and pose a question that's my own, if folks don't mind. So a lot of what we've been working on in our care coordination collaborative here in Vermont is that, there's this team of providers that each kind of has a piece that they're working on, and providers, in a very broad sense. Somebody might be working on housing with an individual. Somebody might be working on wellness and nutrition. Somebody might be working on, finding a job. Whatever those different goals that an individual may have identified are. What are some of those tools that you've used to kind of keep the communication going and, keeping the full picture in place across all those various aspects of, the services that are available to help a person meet their goals?
So I guess I can take that one. We really struggled with that because of the silos in terms of the electronic medical record and just not being able to, document somewhere where everyone can see. So we've got creative, especially with medical providers who want to know about those social situations because they do affect, medical care and getting to appointments and all of those things. So we developed feedback forms is what we call them, and they're a little bit different for each agency depending on what they really want to know about. But our care managers build them out. Sometimes you can even copy and paste a progress note or something that they've already done, because if you add too many steps to what a care manager is already doing, it doesn't seem to happen. So we try to build off what they already have. So they do a 3-4 bullet point summary of the month, and they send that back to the referent or the provider who has requested it, and it's a very basic Word document. The only challenges we've had with that so far is it's easy on our end. It's quick. It takes my care managers probably 5 to 7 minutes if they, have their client file up and ready and they're typing it in. It's what's done on the receiving end. So primary cares have had a little bit of difficulty of figuring out where that goes in their EMR, whether it's scanned in under additional documents, and then teaching people to actually look for it. But we've had quite a bit of success with it in terms of, doctors reaching out and saying, if I didn't, know that they were being evicted, I would have been, more upset that they didn't pick up their medicine, but now I understand the barriers. So it's really helped with the education as well. So communication for us is really using those feedback forms on a monthly basis.
Great. Thanks, Jillian. Super helpful. So I'm mindful of the time. We're coming up on 1 p.m. I think I'd like to ask each of my panelists to share one thing that you would suggest other agencies or care coordinators focus on if they want to improve the delivery of care management. And maybe I'll ask Ari for you to start.
Sure. Just given that last question that you asked, I think it's really worth thinking, being really diligent to think through what you want that integrated care plan to look like. Essentially that's what you're asking of all these, different areas of a patient's life and care that care managers are working on, and, figuring out what's relevant for a provider, and then all of the disease-specific goals that the provider is working on and figuring out what's relevant for the care manager. I think that's a lot of work that we've had to do after the fact because we weren't really set up to do it all from the start. And so, we're working now on an integrated care plan within, multiple sort of care management platforms. And I think that will be something that if you're just starting this up, you could potentially do up front that could make a huge difference in sort of the program to providers and also allowing just for ease of communication from the beginning.
Great, thanks, Ari. And Carlo, can you talk about one thing that you would suggest people focus on?
Right. For me, I believe the relationships that we build, if we could get our care managers or the persons working with us, whether the patient navigators or whatever capacity they're in, when they're engaging with the providers, whether it be mental health or medical providers, or even persons in the community, even in the substance use areas or whatnot, to go with a view or with an attitude of figuring out what is it that I can help you with, what goal can I help you with your patient achieve between this visit and the next visit. What is easiest for you as a provider? What works for you? They're already very busy, and sometimes time is what we hear the most. So go with the view of not only trying to collect information so that you can make sure that your dots are, I's are dotted and your T's are crossed, but go with an attitude of trying to help the provider make their life easier as they take care of the patient. And I think that will open more doors for the care coordinators and make life easier all around for everyone involved.
Great, thank you. And Jillian, what would be your one suggestion for people to focus on to improve their care management program?
I think for us upstate, and it's something that I didn't really have a chance to touch on yet, but being aware of the gray area. So for us as a health home, we love to have a huge network and have everybody all inclusive and it just be this nice, easy flow. However, for us, there are still providers that are not part of the health home network. So we still have care managers floating out there that are not necessarily health home care managers. So as a health home care manager, we came in with this idea of being all inclusive and taking on whatever challenge, medical, mental health, social needs, we were going to cover it all. However, in our area, in our region, we still have housing care managers that are outside the health home. We still have substance use care managers that are outside the health home, focusing on one area. So just being really realistic with those agencies in your community, providing a service that sometimes overlaps with yours, and sitting down with them. We didn't figure out until we, stumbled across a few cases where we were kind of doing the same thing or stepping on each other's toes. It took us all that time to sit down. So know your community, know what services are out there through what agencies, and if there's going to be gray area and if you're going to share clients between a care manager and another care manager, really defining those roles and the limitations of each agency. So if it's a housing person, sitting down with that agency and just saying, listen, we're going to leave housing and A, B, and C up to you, and we're going to cover the rest of it. And using that format going forward with every client you share. That was one of the things that we learned later on that I wish we had learned up front.
Great, thank you so much. So Erin, any last words, or I can wrap here. I just want to check in with you before I say my final words.
Yeah, I'll just do a quick plug for, well, thank everyone for joining us today, first of all, and then do a quick plug for our next webinar in the series. Will be July, so on the screen it says July 26th. We do have a date for that, July 28th, and Holly Stone will be sending out registration information for that event. It'll be a similar time frame. We try to do it around the lunch time, so folks have some free time to attend, and the topic will be domestic and sexual violence, the effect of violence on people's lives, and screening for violence.
Great, thank you so much. So I just want to take this time to thank my fantastic panelists, Carla Francis, Jillian Gross, and Ari Rosner. We so appreciate you donating your time and hearing about your experiences and your expertise. Thanks to all of you who attended today. I hope that I see many of you at future trainings. And thank you again, and have a wonderful day. And we will try to get those tools and flyers and things we talked about to Vermont in the coming weeks. Thank you.
Wonderful. Thank you, Carla.
Thank
you.